Okay, mic is on. Now I can't make any more foolish sounds. All right, so we left off talking about erythrocytes, the most numerous of the formed elements. What are the other formed elements in blood? Yeah, so we have red blood cells or erythrocytes, white blood cells or leukocytes, and then we have platelets. You know what its fancy schmancy name is? Thrombocytes. Clotting guys. Okay, so basically erythrocytes are bags of hemoglobin. When they are matured from stem cells in the bone marrow, which is where all these guys come from, and believe it or not, they come from the same cell, same type of cell. What do you think causes that one type of cell to become all those different cells? It's got to have some kind of signal, right? You need to mature and become a red cell. Is there a voice from above that tells the cell to do that? How does that happen? Hormones! And you already know what the name of the hormone is to make me turn into a red cell. Because you already studied chapter 16, right? What is it? Erythropoietin. So when I need more red cells, and we left class talking about my addiction to the hermit cookie and the fact that I might need more red cells if I have to run to the bookstore when I find out they're selling them, I'm going to call on erythropoietin. Who makes erythropoietin? Kidneys! And they are going to tell me I need to mature that stem cell into an erythrocyte. So a little bit about the hemoglobin before we go on to the maturation process. And do you have to know the maturation process of these cells? Yes. Don't you love that? So we're made of globins, the protein portion. It's a quaternary protein. How many globins? 4. And then we also have heme. And heme is this component, which contains iron, and this is my oxygen and carbon dioxide carrying component of the molecule. So if I have 4 globins and 4 hemes, how many respiratory gases can I carry at one time? Yeah, because the globins don't carry anything. They just hold the heme in place. The heme is the carrier. So I can carry 4 respiratory gas molecules at once per hemoglobin molecule. So when I'm carrying oxygen, we call me oxyhemoglobin. When I'm dropping off oxygen, I get rid of it. What do they call me? Because that's what I do. I carry and drop off. Carry and drop off. Just like that amusement park ride I was talking about, end of class, last class. Yep, we call me deoxyhemoglobin. I can also carry, besides oxygen, carbon dioxide. When I carry carbon dioxide, we call me carbaminohemoglobin. Yes? So this molecule can carry a respiratory gas at any given time. A couple of the factors that are going to determine whether I pick up or drop off. One of them is pressure. When we talk about the respiratory system, we're going to talk about pressure differentials. Atmospheric pressure versus pressure inside your lungs. Correct. Why do people have a hard time climbing Mount Everest? Besides it's really hard, what else? Pressure changes. What happens as I go further away from sea level to pressure in your atmosphere? No less oxygen. The pressure goes down. Okay? So there might be a little less oxygen, but not no oxygen. It's still there. But the pressure gradient change is the problem. Because I want to go, if I'm a gas, from a high pressure to a low pressure. Remember my analogy of pina coladas on the beach, yes? So I want to go from a high pressure to a low pressure. If you don't set up a pressure gradient, I'm going nowhere. So that's the problem when somebody cannot set up a pressure gradient inside the respiratory system. Anybody ever hear of a pneumothorax? Now I'm going to ask this question. I'm going to ask it again when I talk about the respiratory system. Don't tell me it's because I need oxygen, because that's not the answer. Why do I breathe in? No, because I create what inside my thoracic cavity? A pressure gradient. We're going to talk about something called Boyle's law and the size of containers. We talked about this a little bit in the chemistry chapter, but let me refresh your memory. Pressure is inversely proportional to the size of the container. So when the size of the container is small, what happens to pressure in the container? It goes up. When the size of the container is large, what happens to pressure in the container? It goes down. Breathe in. What do you do to the size of your container? You make it bigger. What happens to the pressure in there? It goes down. Less than what pressure? Atmospheric pressure. Where do the molecules want to go? From a high pressure to a... That's why you breathe in. Why do you breathe out? What did you do to your container? You made it small. What did you do to the pressure? You made it high. It wants to go from a high pressure to a... You see where I'm going with that? So if you can't set up that pressure gradient, that pressure difference, you can't breathe in and out. If there's too much pressure on the outside or too little pressure on the outside, those molecules aren't going to move. Well, water's also driven by a lot of attractions from different ions as well. But think about diffusion and osmosis. Things go from a high concentration to a low concentration. That's another thing that's going to drive exchange. The other thing that's going to drive exchange, and I bet you this would be a tough one for you to guess. I'll be very impressed if you guess it. So we talked about pressure. We talked about concentration. What else is going to determine whether or not things go from one place to another? Kind of a chemical thing. This is extremely important. I will give you a major hint. 7.35 to 7.45. pH. If my pH is off, because my respiratory gases are off, exchange isn't going to happen either. Okay, so all those factors are extremely important in gas exchange and have a lot to do with whether this guy is going to pick something up or drop something off. We call that the hemoglobin saturation curve. And all of those factors are going to play a role in a gas exchange. So, where am I? So, sorry, spacing out this morning. When a red cell is immature, it's actually called hematopoietic stem cell or hemocytoblast. And these cells live in the bone marrow. What bone marrow? Red bone marrow. When they're at this stage, they're undifferentiated. These are the base cells, stem cells, blast cells. And they have the ability to change into other cells when they're stimulated by chemicals or hormones. So when I need more red blood cells, I'm going to secrete erythropoietin into the circulatory system, and when it bangs into the hemocytoblast or hematopoietic stem cell, it's going to cause it to do something different, yes? As we know hormones do. In this case, it's going to cause it to mature into a erythrocyte. The cell will start to change and mature, and one of the things it does in the pro-erythroblast, then early erythroblast, late erythroblast, and normoblast stages is it gets ready to spit out what? Let's spit out its nucleus. It's creating more and more and more hemoglobin molecules, and it needs room to do that. And the only way I'm going to create enough hemoglobin molecules in my package is to boot out something that I really don't need anymore when I'm becoming a red blood cell, and that's your nucleus. Am I going to be able to reproduce myself when I become a mature erythrocyte? No. They last about 120 days, depending on what's going on in the system. But before I go into the circulatory system, and how do you think I get from the bone marrow to the circulatory system? Magic? Ping! What do I have to do? I have to get into the blood system. I have to squeeze my way from the bone marrow into the circulatory system. When we talk about the cardiovascular system, we're going to talk about different types of capillaries, small blood vessels. And some of them have big gaps in between the endothelial cells that line them. This will allow this guy in the bone marrow to squeeze into the circulatory system. And I'm going to squeeze in right about this stage right here called the reticulocyte. When I look under the microscope, I can't tell the difference between a reticulocyte and a mature erythrocyte. I have to do a special staining procedure to actually see little fragments of DNA material that's left in the cell. If I have way too many reticulocytes in my circulatory system, much higher than the normal number, what might that mean? For some reason, my body is producing erythrocytes at a very fast rate, faster than normal. We can tell so much from a drop of blood. You wouldn't believe it. So reticulocytes we're going to start to see in the circulatory system, and then the majority of the cells we see are the mature erythrocytes. And again, those erythrocytes are basically bags of hemoglobin. So in order for me to make my hemoglobin properly, what do you think I have to have? What are the building blocks that are very important for me? And this is what they talk about under dietary requirements, page 637. Well, I know I need iron because I have to make my heme, right? And a bunch of different vitamins are extremely important for the whole process of creating hemoglobin. Those B vitamins, for example, are extremely important in the process of creating hemoglobin to pack my red cells with. Some of the different components they mention are things called ferritin, and this is protein-iron components. Remember, I need proteins too, right? Because I have to make the globular portion of my hemoglobin molecule. Hemosiderins are another very important component in creating that hemoglobin molecule. And then we need transport proteins called transferrins to transport my ferritin. See how that goes? To create that molecule as well. So those are some buzzwords you should know with respect to hemoglobin and hemoglobin production. So it's very important to maintain proper numbers of red blood cells for proper gas exchange, both oxygen and carbon dioxide. So we have one of those lovely little negative feedback mechanisms that show us what goes on during abnormal homeostasis with respect to oxygen carrying capacity. So, hypoxia, what's that mean? Yeah, low oxygen carry. And who tells me I have hypoxia? That's floating around in the circulatory system. Low levels, nervous system. And in this case, who's going to help secrete erythropoietin to get more red blood cells? Kidneys. So, low oxygen carrying ability could be due to several different things. Could be due to decreased red blood cells, or it could be due to decreased hemoglobin. Say you don't have the proper nutrients. So you pack your red cells, but you don't pack them chock full because you don't have enough stuff to pack them chock full. So you could also have a decrease in the amount of hemoglobin in those cells. And then you could also just have a decrease in the oxygen available. I'm running too fast. I'm using up too much oxygen. All of these things are going to signal those kidneys and ask them to release erythropoietin. That's going to help stimulate the bone marrow in the maturation process you see on page 636. That's going to enhance red blood cell production. What's that mean? Give me a fancy word for red blood cell production. Erythropoiesis. So erythropoietin stimulates erythropoiesis. Correct. And that's going to help raise the oxygen carrying capacity. That's going to help raise oxygen levels. That's going to help even out homeostasis in the circulatory system. So know the stages of maturation or erythropoiesis for red blood cells. Understand who that immature cell is and what its role is in erythropoiesis. Erythropoietin is under hormonal control, so that's important for us to do as well, or understand as well. And then what do I need diet-wise to make sure that I pack those cells chock full? Iron, ferritin, the B vitamins, all important players in making a good hemoglobin molecule. Okay? Also, it's made of protein too, right? So protein might be an important component as well, right? You are what you eat. You eat shoddy materials, you have a shoddy building. Yes? All right, what's this? The life cycle of a red blood cell. Now, once I'm mature and I get into the circulatory system and I do my job carrying around my hemoglobin and packing my hemoglobin, carrying around oxygen and carbon dioxide, eventually I'm going to start to wear out. Now, I'm very good at recycling. So I'm not just going to throw those cells away. With the help of a very important organ, the liver, and also the spleen, I am going to recycle materials from old red blood cells. So in this diagram, we see that oxygen carrying capacity, increased production of red cells. But when they start to age, right around there in the middle, and they start to become damaged, we're going to recycle them. Now, some of the cells that help me recycle old cells hang out in tissues, and they're called macrophages. They are phagocytic. So with the help of macrophages in the spleen and in the liver, also we find some of these guys in the bone marrow too. I'm going to break those cells down, break them apart, and get their components, the components that are important for me to recycle. Some of them I have to get rid of, but some of them I can actually use again. So hemoglobin is going to be broken down into the heme and the globin portion. And some of it is going to be waste product as I process this. One of those waste products is called bilirubin. Anybody have a new baby lately or know somebody that had a new baby lately? Did they have to go into the tanning bed? You know what I'm talking about? Sometimes when babies are first born, this whole process and their livers have a hard time processing all of the waste products that they are producing from getting rid of some of these old red blood cells that are floating around. And that builds up in their blood plasma. And that is a yellowish, or has a very yellowish tinge. You'll see this also with patients who have problems processing in the liver. People with cirrhosis, for example. They have that yellowish tinge to their skin. They'll actually start to get yellow tinge in the whites of their eyes because the buildup of this waste product, bilirubin, in the blood plasma, which is flowing everywhere and feeding all of our cells, causes it to look yellowish. So another thing the liver is going to help me with is iron. So it's going to help recycle some of that iron. stored as what we call ferritin, and that hemosiderin we just mentioned before, that can put it back into the circulatory system to make more hemoglobin. We can recycle some of those amino acids. But the waste products of red blood cell metabolism hopefully we'll be getting rid of with the help of the digestive system, with the help of that nice gut bacteria that we're going to talk about when we talk about the digestive system. Did you know you have bacteria that hang out in your body? Friendly bacteria. And, yeah, your normal flora or gut flora. Those bacteria are going to help metabolize a lot of the waste products from breaking down red blood cells, along with other things, like releasing very important vitamins, back to my B vitamins again, in the large intestine. So we're going to get rid of some of that stuff, and it's going to be excreted in feces, and that's why your feces is that nasty color, because it's metabolism from that bilirubin and bile stuff. Also, the renal system is going to help get rid of some of those waste products as well. So, important recycling happens with our red blood cells. Disorders. Anything that relates to maybe making hemoglobin wrong is not going to allow me to do what with hemoglobin? Yeah, carry those respiratory gases properly. So think of, and I kind of describe it as a Ferris wheel with 4 seats on the ride. If I don't make the molecule properly, the proper shape, it's going to be hard for you to get in the seat at the amusement park. Say 2 of the seats are crushed. Is anybody going to be able to sit on those on the ride? No, because I didn't make the molecule the right shape. They discuss some disorders, and this disorder I happen to be talking about right now is called anemias. Now there's several different types of anemias, but they're all related to the shape of the hemoglobin molecule for one reason or another. The other one is basic blood loss. So that's the first one they describe under anemias. If I get a hole in my circulatory system and leaking out all over the place, I don't have enough red blood cells to carry my respiratory gases. And that's described under blood loss or hemorrhagic anemia. What if I don't have enough red blood cells for some reason? Maybe my erythropoietin hormone is off. Or maybe the receptors on my hematopoietic stem cell is off. So the message isn't being conveyed properly. And I might have not enough red blood cells produced. Too many red blood cells. Well, that's not a problem, is it? Yeah. Remember, all that stuff has to flow around in suspension, plasma, through your circulatory system. If you have way too many red blood cells, what might happen? They can plug up the works. They can plug up the tubes. They can get caught up in our capillary beds. It makes the blood too thick. And that can be an issue as well. Some people do that on purpose. No, something called blood doping. Some athletes will do that. Why do you think they do that? Sorry, I need a coffee. You guys are sharp today. Gives them increased oxygen carrying capacity, but it also increases their chances of doing what? Having a stroke or an embolism. Yes, so not such a good idea. This guy described up here, you've probably heard of before. It's called sickle cell anemia. The other one they mentioned in your book is thalassemia. We see this typically in Mediterranean and Greek ancestry, and it's a problem with the hemoglobin molecule, a defect in the shape. This is a scary one, because way back when we learned about transcription and translation, you remember that well, don't you? And we talked about proteins being made of chains of amino acids. And this is a pretty gosh darn big protein, isn't it? Big 4 globs. It's a pretty good sized protein. So it's made of lots and lots of amino acids. One mistake, right there. gives us the difference between a normal hemoglobin molecule, which is nice and big and full and fills up our red blood cells, and an abnormal shape, half the ride is crushed hemoglobin molecule. So it doesn't fill up the cells as well. So they kind of fold in on each other and create some of the cells, and we'll see these under the microscope next week, that look like a what? Look like a sickle or a half moon. That's sickle cell anemia. So they talk a little bit about that. Polycythemia, too many cells, not good. Talk a little bit about blood doping on page 640 for us. So to have a general understanding of some of the different anemias they talk about, understand what anemia is. Abnormal shape of those hemoglobin molecules or not enough cells. Next, formed element. Our friends, the who? The white blood cells or the leukocytes. Remember I did this last class? There's 5 different types of white blood cells. What did I tell you to remember? Never let monkeys eat bananas. Neutrophils, eosinophils, basophils, lymphocytes, monocytes. But never let monkeys eat bananas. Remember them in that order. Why do I want you to remember them in that order? That goes from highest to lowest of number. So never let, you see where I'm going with this? Monkeys eat bananas. 2 different categories of leukocytes. And remember, leukocytes are much lower in number than erythrocytes. Remember when we looked at that picture of the blood in the beginning of the chapter? We saw tons and tons and tons of erythrocytes in the picture, and maybe 1 or 2 leukocytes in the picture. They number in the thousands. What did the red blood cells number in? The millions per drop. So we have a lot less of these guys. They hang out where when I spin out my blood tube? Where did I find them? Right in the center in that little bitty stripe called the what? Not called shit, no. Buffy coat. That's right. So is the Buffy coat in the center. So this is where we're going to find these guys in my tube of blood, much lower in number. These guys are going to help with protection for our system. Remember those macrophages I talked about before? Well, they used to be these guys hanging out in the circulatory system. Then they squeezed their way into tissues and started to phagocytize things.
When you spit down blood in a certain separated tube, it has that gel on it.
Mm-hmm.
Where do you find your white blood?
Underneath the gel. It's stuck, yeah.
Under the gel with the red blood cell.
Yeah. And you can't see it because it just, it sticks to that gel stuff. So, okay, back to where I was going. Okay, so these guys are going to help us with immunity, protection. The reason they're hanging out in the circulatory system is so they can survey the whole body. So they're basically just hooking a ride in the circulatory system to where they have to go to make sure that you are protected from any foreign invaders. Some of them, the phagocytic members of the 5, have the ability to phagocytize things and can undergo something called amoeboid motion. Do you ever watch an amoeba move? Kind of sticks its arm out here, sticks its arm out here, and can grab things and bring them into the cell. So our phagocytic members of the 5 undergo that amoeboid motion. They also have very keen abilities to detect certain chemicals in blood. We talked a little bit about something called chemotaxis last semester. Do you remember that? When we talked about the integumentary system and healing a wound. What was chemotaxis? Oh, it's time to drink. Chemotaxis. Nothing. It's a chemical attraction that cell has, telling it where to go. So chemotaxis we talked about when tissue got damaged, when I cut myself. I described it as kind of cracking an egg open and releasing the chemicals from the cell. Those chemicals are detected by many of the phagocytic members of the 5. And they can migrate to that area and go phagocytize any nasty bits that might get in when you cut your skin. So chemical messages that attract cells. That's what chemotaxis is. So they have the ability to move through the system, move out of the circulatory system to get places too. They are broken down into 2 categories. And basically they're broken down into 2 categories based on what they look like under the microscope. When I look at them under the microscope and I stain them with a very specific stain called Wright stain, and Wright stain is a combination of a whole bunch of different colors. Based on the chemical properties of these cells, those colors are going to be pulled out, react with those chemicals within the cell, and you'll visualize them as different colors under the microscope. So these guys, when I look at them under the microscope, those granulocytes, and there's 3 different ones, neutrophils, eosinophils, and basophils. These aren't the greatest pictures, but if you look at these cells, by the way, white blood cells have a nucleus, but these guys have a weird nucleus. It's not that nice little round that we see in all of our cells, like the epithelial cells and the neurons and the muscle cells. It's kind of weird. In the granulocytes, and we call them granulocytes because those chemicals I talked about in the Wright stain, when they react with these little packages of chemicals that are contained in the cells, they produce color. In the neutrophils, we're going to pull out the neutral portion of the stain. And the granules are almost like sand in the background. They're not very pronounced, but they're all over the place. And it picks up the neutral portion of the stain, which is what I describe as pinky purple. So when I look at them under the microscope, I'm going to see all those sandy granules in the background, and then I'm going to see that weird nucleus. The weird nucleus, as it matures through the maturation process, we'll talk about in a moment, is formed and creates multi-lobes. You ready for a big word? The other thing we call these cells are polymorphonuclear leukocytes. Yep, PMNs. Sometimes lab geeks throw that out there. They like acronyms. They impress themselves with them. Right? Right? So break the word down. Poly means what? Many. Morphology refers to your visual, what you're seeing. Nuclear, the nucleus, and it's a white blood cell, leukocyte. So these cells, the granulocytic series, have weird shaped nuclei of many different shapes. When we look at them under the microscope, we'll prove that for you. So polymorphonuclear leukocytes, or neutrophils if I have my pinky purple granules. If I have, and this is a really bad picture, imagine the granules a little bit bigger. So we can actually see almost balls now of these little packages of chemicals. They stain orange, the eosin portion of the Wright stain. So when I look at this cell under the microscope, I can tell it's an eosinophil because of the orange granules that I'm going to see dispersed throughout the cell. And again, that picks up the eosin portion of the stain. Basophils pick up the basophilic portion of the stain with their larger granules. And the color is what? It's like really, really dark blue, almost black looking. This is the lowest in number. And when we look at them under the microscope, it's hard to find these guys because it's typically less than 1%. one or two you might find when you look for them. So we describe them based on their stain under the microscope, based on right stain results. The one in your textbook is much nicer. They finally got a decent eosinophil in there on page 641. This is the old thing, so sorry about that. So if you look at figure 17.10 on page 641, you are going to see much nicer representation of the granulocytic series. These guys can be phagocytic. Neutrophils are the largest in number. They're also phagocytic. When they squeeze out of the circulatory system, become macrophages, they can go help out cleaning up tissue debris. One of the things that are going to help get rid of nasty substances are chemicals contained in those little granular packages. Some of them are called defensins because they defend you from what? Foreign invaders. Remember when we talked about phagocytosis way back when? And we talked about a phagosome, and then we talked about a lysosome, and the two merged to become a phagolysosome. The lysine chemicals broke down the nasty little critters that were taken in, and then what did I do with the waste? What's that called? Exocytosis. Remember that? That's what these guys are doing. So those granules are packages of different chemicals depending on the cell. If I have an eosinophil, which is about 2 to 4% of the leukocyte family, those guys have larger granules. We tend to see that orange color. And we tend to see them higher in number when we have things like allergic reactions. During allergy season, if you go get your blood drawn and you have a test done called a white blood cell differential, if you are in full bloom allergy, your eosinophil number might be a little bit higher. The other thing we see higher in number when we see eosinophils higher in number is sometimes people have parasitic infections. So we'll see them higher in number, and again their granules are going to help destroy those predators in the body. And then last but not least we have the basophils. And those guys, very small in number, 0.5 to 1%. I keep throwing out this percent. How do I figure out the percent of these guys? Huh? That's exactly what you're going to do, and you're going to do it in lab. So you go count 100 white blood cells on a blood smear. And that's what you're looking at every time you see these guys. They're from a blood smear. So I take a drop of blood and I smear it on a little glass slide and I run it through a stain so I can see the pretty colors. And then I go count 100 red blood cells. And as I count them, I say who they are. So if I only find 0.5 to 1% basophils typically in my 100 cells, how many would I have counted? One. Or none. Because remember, it's an average, right? Of the 100 I count. Who's the guy that's going to be the most out of the 100 I count? Neutrophils. Who's next? Lymphocytes. Monocytes. Eosinophils, basophils. Yes? That's why you need to remember, never let monkeys eat bananas. So most of your cells that you count in a normal white blood cell differential are going to be what? Neutrophils and lymphocytes. Yes? So basophils have little packages that contain histamines. And histamines are going to help with what? Inflammation and inflammatory responses. Mast cells. We met those guys when we talked about connective tissue way back when. Remember those guys? They used to be who? before they squeeze out of the circulatory system into tissue? They used to be basophils. Okay? So again, those cells we're going to find in connective tissue. They are going to help with histamine release, inflammation, and that's the granulocytic cells. The other two guys, we call them what? Agranulocytes. Now that's kind of a misconception, because when we look at them under the microscope, every once in a while, guess what we're going to see? We're going to see some granules. But for the most part, they're not as granular as the granulocytes. They don't have as many packages of chemicals as those guys do. But again, the stain, the right stain, is going to play a big role in whether or not I describe these cells as one or the other. The next, or the first, they describe in your textbook of the agranulocytes are the lymphocytes. Now, lymphocytes' nucleus looks much different than the granulocytes, right? Now we get back to that nice big round nucleus that we're used to seeing. The other distinguishing characteristic of a lymphocyte is its cytoplasm. You can't quite see it up on the board, and it's not really great in your book either. But when you look at it under the microscope, its cytoplasm is going to pull out very specific blues from your right stain. And its cytoplasm is going to appear, and sometimes it's described in hematology books as something called robin's egg blue. So a nice blue cytoplasm. In this slide, we see something called a small lymphocyte. In a small lymphocyte, the nucleus takes up most of the cell, and we have very little cytoplasm. We can also have large lymphocytes. Again, what am I going to look for to tell me whether or not it's a lymphocyte? That nice round nucleus, and it tends to be more densely packed than this other cell I'm going to talk about in a minute. And what else? The blue color, that blue cytoplasm. So that's a lymphocyte. We're going to talk about that guy in much more detail when we talk about what chapter? The immune system. We're going to talk about these guys and their role in helping to protect you. Now, their role is a little bit different. Their role is to organize everybody else and tell them what to do when a foreign invader comes in, or their role can be making chemicals to help neutralize foreign invaders. So when we talk about T cells, which is the guy that's the coordinator of the movement, or B cells, the guy that makes the chemicals, does anybody know what those chemicals are called? Chemicals you have floating around in your blood to help neutralize foreign substances. Begins with an A. Antibodies. We're going to talk about these guys in more detail. So again, B cells and T cells are different types of lymphocytes, and they're going to play a different role in the immune response. That's coming. It's exciting. The other agranulocytic cell we're going to see under the microscope is something called a monocyte. Monocytes just hanging a ride in the circulatory system. Where does it eventually want to go? And we talked about this last class. Maybe. We can go in connective tissue and become a macrophage, but what else? Had something to do with my delicious sundae from Friendly's. Osteoblasts. So remember when we talked about calcium levels and parathyroid and calcitonin and their roles in maintaining calcium levels? When calcium levels go down too low, parathyroid hormone is going to stimulate Mr. Monocyte hanging out in the circulatory system to do what? Change into who? Osteoblast. We can also, this guy's also a macrophage in the tissues. So he has the ability to be phagocytic as well. Difference visually. Much bigger cell, the largest of all 5. Not very organized. Like these guys are pretty organized. Nucleus nice and round. Cytoplasm nice and round, except for the messed up nucleus in those granulocytic cells. But this guy here, holy moly, he's all messed up. He's big. His cytoplasm is not blue, it's more gray. And his nucleus, hell knows what I'm going to see under that microscope. The nucleus is large. We're never going to see polymorphonuclear, but we might see kidney bean shaped. We might see round. But the characteristic we have to look for is how densely it's packed. So in a lymphocyte, dense packed nucleus. In a monocyte, more airy. So I see little white spaces when I look at the nucleus of a monocyte versus the nucleus of a lymphocyte. The reason I point this out is because that's the biggest mix-up when we're doing a white blood cell differential. Many people think that's a lymphocyte. No, that's a monocyte. Yes? Remember the colors. Remember the nucleus. So the monocyte is also described. Again, it can be a phagocytic cell depending on where it hangs out and what it's doing. Here's the scary one. Oh, no. Maturation series. Do you have to know this? Yes. Now, it was erythropoietin that caused the hematopoietic stem cell to mature into an erythrocyte. Well, what exactly is it that causes the hematopoietic stem cell to do so many different things? Chemicals. So, there's a group of them called cytokines, interleukins. I'm trying to find where it is in your book. But there's a group of chemicals, and I'm not going to make you know each one and each one that causes what. I just want you to know the name of the group. So, lymphoid stem cells, myeloid stem cells. That's the first separation of progression that can happen in the leukocyte maturation process. And again, different chemicals will cause that to happen. If I become a lymphoid stem cell, I'm going to become a what? Lymphocyte. If I become a myeloid stem cell, I might be 4 different cells, depending on the chemical that stimulated me. So the maturation process, again, is a little bit different with respect to lymphocytes versus the other 4 members of the family. Do you have to know the process? Yes. Monocytes can squeeze out of the circulatory system and become what? Macrophages. Some lymphocytes can squeeze out of the circulatory system and become what? Plasma cells. When we talk about the immune response, we're going to talk about B cells, B lymphocytes. And that's what they will do, squeeze out of the circulatory system and become plasma cells. And plasma cells make antibodies. Okay, so when you become immune to something, did everybody have a flu shot or a vaccine or something like that? Once in their life? Yeah. You don't believe in that stuff? Yeah. Take a course called Emerging Infectious Disease, and you'll never miss your flu shot again. No, you don't. We'll talk about that when we talk immune system. But anyways, those particles that we find on the surface of cells, we call them antigens, will cause these cells to recognize them as foreign and make specific chemicals to neutralize them. And that's what you do every time you get a flu shot or a vaccination. You're given the specific antigens that a disease might cause, like a virus, for example. Your body recognizes them as foreign because of these cells. Remember T-cell kindergarten we talked about? Where was that? The thymus? We're going to talk about that more. But that's where cells go to learn to recognize self-antigens, because you have antigens on the surface of your cells, and non-self antigens. And that's going to help with an immune response. And again, we'll talk about that more when we hit that chapter. So know the maturation process. When we look at very early on, just before I get spit into the circulatory system, our granulocytes, we see that their nucleus is kind of kidney bean shaped. And then when they get spit into the circulatory system, that's when the crazy shapes start happening. If we look at our cell under the microscope and we see lots and lots of this kind of cell in our slide, what might that tell us? That I'm, for some reason, doing what? Making way too many white blood cells than normal. So if I start to see more, and they call these guys bands, if I start to see a higher number of those in my slide, I know you're making a lot of white blood cells for some reason. So if I have a bacterial infection, for example, I might see a lot more neutrophils, which normally would be fine, that are bands. Why? What's a neutrophil going to help me do? Get rid of bacteria, right? If I have a bacteria in my body, I need to make a lot more to help me do that. Another thing I might see a lot of in my slide due to infection is a viral thing that causes these guys to kick into gear. Anybody ever hear of mononucleosis? It's caused by a nasty little critter called the Epstein-Barr Virus. And when I look under the microscope at my slides, I'm going to see a lot more lymphocytes. But they're not going to be your typical lymphocytes. They're not going to be those nice round shapes. They're going to kind of have weird shapes to them. And there's going to be a lot more of them. We call these guys atypical lymphocytes. And that's an indicator that you might have mononucleosis. So that little drop of blood on that little piece of glass can tell us so much about our patient, and it can do it very quickly. So that is my leukocytes. Now, I just want to point out, and you're going to notice this if you're crazy about numbers. I'm not going to get crazy about numbers. I want you to have general ideas of numbers. On page 644, table 17.2, you're going to see the cells, the formed elements we talk about, a description of what they are, and numbers. That's, I think, where I want you to know. Actually, I'd rather you, with respect to the leukocytes, know the numbers in figure 17.9. So when I go back to figure 17.9, I see numbers for the white blood cells. Yep. So those are the numbers I want you to know. From the table on page 17.2, 4 to 6 million, excuse me, on page 644, table 17.2. When we talk about large numbers, I want you to know those. So if I look at a drop of blood, and that's what a cubic millimeter is, I'm going to find 4 to 6 million red blood cells. And if I look at a drop of blood, I'm going to find 4,800 to 10,800 white blood cells. The chart on the other page is where I want you to know each of the ones, 50 to 70%, 20 to 30%. Am I making sense? Okay, good. And platelets, the last guy I'm going to talk about in the formed element family, is actually fragments of cells in the circulatory system. 150,000 to 400,000 fragments is what we're going to find per drop of blood. Same cell, hemocytoblast or hematopoietic stem cell. But who's going to cause it to change into this guy? Another name for a platelet, I'll give you a hint, thrombocyte. Its hormone name is thrombopoietin. And who makes that? Do you know? I'll give you a hint. People with cirrhosis have trouble blood clotting. Liver. So thrombopoietin is released when I need more help with blood clotting. And I should have, again, on any given day, between 150,000 and 400,000 platelets per cubic millimeter. These guys don't last that long either. About 5 to 10 days, typically. But they're going to help with the clotting process. Do you have to know the maturation process of a platelet? Yes. And just before the platelet comes on board, or the fragment of cell comes on board, in the bone marrow, if we look at the maturation process, we produce this giant cell. It's called a megakaryocyte. And when it goes to squeeze into the circulatory system, guess what happens to it? It blows up. Exactly. Because it's too big, can't fit. And the fragments that are left behind are what we see in the circulatory system as platelets. Before I get too far away from the other members of the family and the leukocytes, I do want you to have a little bit of an understanding of what leukemias are. What's leukemia? It's basically abnormal production of one of these members. So depending on which member goes astray, and basically it's cancer of your white blood cells. And they start reproducing themselves very quickly and wreaking havoc through the body. So we can have a lymphocytic leukemia, we can have a basophilic leukemia, we can have a neutrophilic leukemia, depending on which cell. Yeah, well, yeah. And there's even more depending, there's different subcategories of different cell types. But typically myeloid lymphocytic are those common ones that you hear. And because these guys are meant to protect your body, when they go awry, body doesn't get protected. Body might actually get attacked by cells that just don't know what they're supposed to do anymore. No, I don't think they typically categorize leukemia as an autoimmune response. It's more of an abnormality of. So, didn't want to get too far before I said that. So, thrombopoietin is the hormone, liver is the player, and then the karyocyte blows up and releases platelets into the circulatory system. So what are platelets going to do for me? Help form blood clots. Give me a fancy science name. Hemo, which is blood, stasis. So when I describe hemostasis, what is hemostasis? Blood clotting, exactly. So on page 646 in your textbook, they start their description of hemostasis. Oh, there's numbers again. Oh, how Maria likes those numbers. So what is the process of hemostasis? Stopping the blood from flowing out of the tubes, circulatory system. When I cut myself, I basically put a hole in my circulatory system. And if I don't plug up the hole, what's going to happen to everything in the circulatory system? It's going to leak out all over the place, which is not good. The platelets are going to play a big role in helping me stop the bleeding. And the first thing that happens when I cut into that tissue, just like cracking an egg and releasing all of its innards, just like we described in what process that I just talked about near the beginning of the class? Yeah, when I talk about tissue repair. The same kind of things are going on here. So I'm releasing chemicals from the cells that line blood vessels. When we talk about the circulatory system, we're going to talk about cells called endothelial cells. Basically epithelial cells that line tubes. When I crack them open and release the chemicals, they're going to start this ball rolling. One of the things they're going to cause is something called vascular spasm and vasoconstriction. Why do you think vasoconstriction would be helpful if I have a big hole in my tubes? It makes it smaller, kind of helps to block off or slow the flow a little bit and try to get repair going. The next thing that's going to happen because of those released chemicals and because of the fact that chemotaxis can happen with these cells that we just described, they're going to get the signal, that chemical signal, to come to the area. And chemotaxis is going to help platelets come to the area that's been damaged. So the second step is what we call platelet plug formation. It's going to help bring a whole bunch of things to plug up the hole. And platelets are then going to release chemicals that are going to help create like a sticky bandage. Now, along with the platelets themselves in this sticky bandage, these chemicals are also going to cause a clotting cascade. Remember when we talked about plasma, we said there was a bunch of proteins in there? And we said some of those proteins were liquid, floating around in the circulatory system, but at some point I might be able to stimulate them to become a solid? Do you remember that? Platelets and their chemical release can cause some of these normally liquid proteins to form a solid. It's called fibrin. I'm going to talk about it in a minute. But it's kind of like mesh. You ever get one of those little gauze pads if you have a cut? So if you take a gauze pad, it's made of all these little fibers, right? Think of fibrin in that way. So platelets, along with one of those little fibrin gauze pads, are going to create what we call a platelet plug. That's going to help plug up the hole, and it's going to help stop the bleeding. Coagulation is the formation of the plug. And again, it's going to be a combination of not only the platelets that attracted everybody to the area, but those fibrin threads that form that mesh to plug up the hole. So those are the process or steps of hemostasis, and you should know that. This is the scary part of hemostasis. This is the actual chemical reaction. On page 648, these are all of the different chemicals involved in forming that gauze pad. Not so easy, right? When you go to medical lab school, when you become a clinical lab technologist, you need to know all of these clotting factors. Scary if you want to find out what they are. They're on page 647, table 17.3. And they're described as blood clotting factors or procoagulants. All of these 13 guys are going to play a role in forming that fibrin mesh. Am I going to make you memorize all of those? No. But what I do need you to understand, and if you look at these diagrams, if you look at the diagram in your book, again, that's figure 17.14 on page 648. What you do need to know is the stuff that's in the box. So, there's two ways to form a clot. Intrinsic pathway, extrinsic pathway. Intrinsic pathway. As things are flowing through those tubes all the time, the tubes get a little worn. Yes? especially if you have like high blood pressure or a lot of pressure in an area. Those endothelial cells aren't going to last forever. They're epithelial cells, right? So they need to be replaced. So I might have to replace some cells, undergo a little repair and construction. And I might need a little clot in the area to help me do that. That's the intrinsic pathway of clot formation. Both of these guys are going to lead to the same thing, just in a little bit of a different way. Again, am I going to make you memorize that? No, but you do have to know there's two different pathways. Extrinsic pathway, I come over and punch you from the outside. I come over and cut you from the outside. We're going to create that clot. Again, common pathway is down there on Prothrombin Activator stage. But I'm going to go about it a little bit differently. So I'm going to use some different clotting factors and different chemicals in different places. So know the difference between intrinsic and extrinsic. And know that in the intrinsic pathway, I'm going to be counting on something called PF3. And that's going to be released by the platelets to help me get to the common place. And the common place is the formation of something called Prothrombin Activator. Once I have that, it's going to start the whole mesh formation for me. When I cut my cells, I'm going to release chemicals from the cells. We're going to call those tissue factors. And those tissue factors are going to get me, in a roundabout way, to the same common pathway. What is it? Making that prothrombin activator. So if you look at your diagram, you see that's common line. That's what I need to make to form a clot. I'm going to do it differently depending on intrinsic or extrinsic stimulation. You with me? Oh, wait a minute. There we go. So, oh yeah, that's all the factors. So if you look at that diagram, you're going to find them all in there in some way, shape, or form. What else are you going to find in there? What else is going to help with you blood clotting? Calcium. Calcium is very busy. Calcium is going to help with muscle contraction. Calcium is going to help with nerve impulses, and it's also going to help with clotting as well. There's another guy in there called vitamin K. I don't see him in your thing. He's going to help too. So vitamin K, not potassium, vitamin K, different animal, is going to help with clotting as well. So, along with all of these little factors in calcium and vitamin K, I'm going to form something called prothrombin activator. And once I have that there, it's going to start a chain reaction, and it's going to help activate things in phase 2 of the clotting process. And we're going to form something called prothrombin 2. When it's formed, it's going to activate other chemicals and form thrombin 2A. When that's around, guess what's going to happen next? That soluble fiber that's normally floating around in the circulatory system, and before this happened, we called him what? Fibrinogen. That's the soluble protein floating around. Once thrombin 2A is on board, it's going to convert that soluble fibrinogen into a insoluble what? What's it called? Fibrin. And with the help of some calcium and a couple more of those factors, we're going to form that mesh. It's going to trap platelets and plug up holes. So that's how I form a platelet plug. That's how I form a clot. Now sometimes if my chemical balance is off, I can form clots when there's no holes. Is that a problem? Yes. What's a bigger problem? when those clots that might be sticking to the side of a blood vessel decide to travel. They come loose, they break free, and they start traveling through the tubes. And eventually they're going to get plugged up somewhere. And they might get plugged up in your heart. And what's that called? You just said it. Myocardial infarction. Yes? If I plug up the tubes, somebody's not eating. Yes? And what's going to happen to the tissue past that infarction or disruption or blockage? It's going to start to die. Yes? If it happens in the lungs, pulmonary embolism, stroke, cerebrovascular accident. Yes? So if it starts to travel, we don't know where it's going to end up. And it might end up in some place major like that and cause some major damage. So thrombus, sticking to the side, embolus, taking a travel. They're both clots. Yes? We don't like the embolus. We don't like the thrombus either if it's not meant to be there. But we really don't like the embolus because that one's on the move and we don't know where you're going to end up. Yes? So when I do this repair and I form these clots, especially in the intrinsic means, I just don't want to, when I'm done, like rip off the bandage and throw it into the circulatory system, do I? Yeah, that's a problem. So after the repair has been done, when I form a clot or a thrombus, what has to happen next? By the way, that's kind of what it looks like. Yeah, everything gets caught up in there. It's very sticky. It's like spider webby, and you might get some red blood cells that get caught up in there. But the fibrin portion is all the things that looks like threads. So the next thing the book talks about is taking care of the clot. Don't look at this. This is the end of the book. I have to then dissolve that clot very systematically. I have to sort of go in reverse to make those insoluble threads back into what? Soluble threads, right? Fibrinogen. I like that better if I'm going to start flowing around in the circulatory system. So the next thing they talk about in the textbook is something called clot retraction and fibrinolysis. What's that? Break down fibrin. Lyse it, break it down, make it soluble again. So clot retraction and fibrinolysis is what's going to help dissolve that clot and put it back into the circulatory system. So anything that disrupts this clotting cascade can disrupt the formation of clots. Any deficiency in any of the clotting factors or some chemicals that I might put into the body to disrupt this pattern. And we actually do that sometimes, and we do it on purpose, especially when we have patients that have increased chance of forming those thrombus or potentially embolus for whatever reason. Maybe they had surgery. Maybe they have a lot of disruption in their body. Problems with banging around in the heart, maybe, or banging around somewhere else. We're going to actually give them chemicals to disrupt this clotting process. Those chemicals are called anticoagulants. Popular ones are heparin, and that's, we have to actually give that to you in an IV. Or another one that you might have heard of is Coumadin. That's an oral medication. And they're very, very hard to regulate. So we're constantly, especially when patients have other medications on board, or disease states like diabetes, for example. They're very hard to regulate, but those are some of the popular ones. And those are given so that we prevent the, according to the textbook, undesirable clot. We don't want those guys just floating around. They describe that process under thrombolytic disorders. So thrombi and emboli, unless I'm there to plug up a hole, aren't normal. So anticoagulant drugs are very helpful, again, with situations where a patient might be doing this spontaneously. Aspirin is another one that does this, anticoagulant. Sometimes we take it for a headache. People say it helps thin the blood. Not really. It just helps you prevent clot formation. And that's going to help with better flow. Warfarin is another name for Coumadin, and they mention that under anticoagulant drugs. Again, that's a very popular oral anticoagulant that we give our patients to stop that undesirable clot from forming. Next thing they talk about is bleeding disorders. Thrombocytopenia. What's that? Yeah, a deficient number of platelets. What's that mean? Yeah, not enough platelets, you might have problems clotting. Hemophilia. What's that? You have a problem clotting. How come? Not because I don't have enough platelets. It's one of those factor 8. They used to think it was factor 13, then they called it something called the Christmas tree factor, but now we're into factor 8 these days. So factor 8, a deficiency in one of those little chemicals of all that big chart on the other page can stop you from clotting properly. And that is a genetic disorder. Anything that's going to impair liver function. Because why is the liver so important in the clotting process? Why was the liver important in the clotting process? What does it do? It makes what? Thrombopoietin, yes? So if I don't make enough platelets because I have problems with my liver, because I have problems with the chemical, I am... Why is it that? That's stupid. There we go. All right, I just want one clicker question. So here's the deal for the rest of this week. We don't have much to go to finish Chapter 17. And guess what's happening when we finish Chapter 17? We have a test! So I'm giving you a break. I kind of lengthened the lecture today purposely because we're going to finish Chapter 17 on Thursday. When's your exam? Tuesday, next week.
We don't have a Chapter 17 quiz.
Yes, online.
So we have the quiz and then we have the test.
Correct. So on Thursday, the same thing will happen, which has happened in the past few days. The quiz will open up. So after class on Thursday, the quiz for Chapter 17 will open up. The other present I am going to give you on Thursday, and pay close attention to your CM Connect email. If you don't read your CM Connect email, you better on Thursday. Because I will give you some helpful hints on possible essay questions that will also be included in your exam on when? Tuesday of next week. So your first exam is going to be a combination of multiple choice and essay. And it's going to be on Tuesday of next week, and it's going to be on chapters what? 15, 16, and 17. That's a whole hell of a lot of material. So hopefully you guys have been studying all along. Yes? Okay. Answer the question. After centrifuging of the listed blood components, which contains the components of immune function? Who are the guys that were going to help me with immunity? Did you click out? Don't put it away. I might ask 2 questions. 5, 4, 3. Just click because I got to take attendance. So click. Guess. 2. Everybody click? Good. What's the answer? The answer is B. Oops. B. Not erythrocytes. Erythrocytes are bags of hemoglobin. All they do for a living is what? Carry respiratory gases, oxygen, carbon, and no immune function whatsoever. So the answer is B. Let's do one more. The major function of most common plasma protein, albumin, is what? Oh, 5, 4, 3, 2. I thought there were 32. Was there 31? Or 30? Oh, 32. What's the answer? Oops. No, it's not. Yes, D. I'm sorry. It's like both A and C. I thought C was in my brain. I'm like, only one person with C. D is the answer. Okay, good. So we'll finish up this chapter. It will take us like 2 minutes. And then we're going to start the next chapter. So, tough tooties. We're going to do it. Don't forget to go check your attendance. If I marked you absent and you were here on Thursday, make sure you send me an email and let me know your clicker number so I can manually do that.